Thanks for the opportunity to speak today. When we think about uACR screening, we recognize that this is an opportunity for us to assess the kidney, but also recognize that assessing the kidney in this way allows us to assess the risk for heart-related events that matter to our patients, like heart attack and heart failure. And what we've really come to appreciate over the past several years is that the power to really, as the campaign is about detecting the SOS, the power to really detect cardiovascular risk as it relates to a full comprehensive assessment of the kidney is an opportunity to really provide to our patients more information about their risk for these types of events. We've learned that this protein, albumin, which is really there to protect the circulatory system, including the kidneys, it helps keep blood in the blood vessels. And when the kidneys are inflamed due to systemic disease like metabolic disease associated with diabetes or high blood pressure, that the kidneys are going to give us this signal by leaking that protein into the urine. And that's really the concept behind uACR measurement. I think there's two big categories. One is there's a education gap, and that's the reason for the campaign, is to raise awareness. I think we need to raise awareness for both the patients to be aware so they can talk to their physicians and their clinicians that are taking care of them, but we also need to raise awareness among those who are providing the care. I think that we have sort of seen this as sort of the kidney domain. And I think that's been part of the problem is we've sort of said, look, that's up for the kidney doctors to focus on with the patients, but there's not that many kidney doctors proportional to primary care or cardiology practitioners, endocrine physicians. And I think the reality is we need to make this everybody's responsibility, not just the kidney doctors. And I think the information gap is a big problem. I think the other side of the coin is that we have still some challenges with implementing these types of therapies from a systematic mechanism. So changing the defaults, for example, in the book Nudge, we talk a lot about how, if you change the default to sort of opt out of something as a system intervention, it makes it much more effective as a default. So for example, in my clinic, in my practice, 90% of patients receive the uACR testing as part of an intake because we've standardized the lab as just part of a best practice for those patients that have high blood pressure or diabetes, which is the majority of the patients I see in my practice. Well, patients are used to getting, routine labs, annual labs, et cetera, ordered by their physician, for example. Even in the primary care practice, they're used to a battery of labs and potentially tests that is part of their kind of wellness checkup. And so really, we just kind of partner with that concept. And the idea being that, the standard blood test assessment of the kidney function gives you an assessment of the filtration, sort of the GFR, as we call it, the filtration rate of the kidneys. But that's only one side of the equation in assessing the kidneys and the cardiovascular risk comprehensively. And what I try to teach my patients is that even when that GFR filtration rate can look relatively normal to your physician, if we check a uACR in the urine, we may see that there's significant elevations in that albumin protein loss in the urine, that uACR can be quite elevated in patients with diabetes and high blood pressure. And that gives us additional understanding of the patient's kidney disease as well as their cardiovascular disease and cardiovascular risk. So, for example, for patients that have there's about a third of patients who have normal-ish looking filtration rate that still have significant elevations in uACR. Those patients with elevations in uACR but normal-ish looking GFR filtration rate, they still have significant threefold, fourfold increased risk for cardiovascular events that matter, such as heart failure, very devastating and disabling disease that's really burdening our society today. Great question. And it's something that we've been working on with our Cardiometabolic Center of Excellence here in Kansas City and with other sites that are similar in orientation and philosophy. And what we've realized is that best practice is to implement systems that essentially standardize these types of changes in implementation. So order sets that are automated based on patient criteria. So again, for my particular clinic and center where I work, all of the clinicians, including our nurse practitioners and physicians, have the same standardized approach when we bring patients to us. And so if a patient is referred to see us for diabetes or obesity related complications like cardiovascular disease or chronic kidney disease, as an automatic part of the intake, they get their vitals, their heart rate, their blood pressure, their waist circumference. And then they also get some basic labs like their A1C to look at, how well their sugars are doing. And then of course they get the uACR as part of it because of the evidence supporting its ability to help us with cardiovascular risk stratification. So this is what works. And so if primary care practices, cardiology practices can join forces with the kidney doctors and kidney clinicians, we can actually improve the ability to detect the SOS, as we're talking about the campaign, to detect elevations in uACR, to further identify patients at risk. And of course, we have a number of therapies we can offer patients who have elevated risk. Well, we know when patients are educated, and of course, it's very effective when you have celebrities who actually have experienced either the disease themselves or they have family members that have experienced this who can be advocates for the campaign. It's very powerful. It's essentially a marketing strategy, but the marketing here and the message here is to raise awareness for patients themselves to know about the ability to detect increased risk for cardiovascular events related to the uACR. And we know this is a very effective nudge for clinicians. So when a patient shows up in the office and says, "Hey doc, I saw the big game commercial. What do you think about checking this as part of my comprehensive risk for my heart and for my kidney health?" Guess what? Those primary care docs are going to start checking. And so you can nudge clinicians directly. You can also nudge patients with raising awareness. And as they bring that information to their doctor visit, they will most likely be able to achieve, a partnership with their clinician to increase the awareness of this and actually address the risk stratification with the laboratory check. I think the most important key takeaway is that we have opportunities to comprehensively assess the kidney and heart disease risk and status. And by checking a uACR, we are able to do a much better job addressing that risk with the patient and offer the best therapies that we have to really get upstream and prevent progression of cardiovascular and kidney disease and actually prevent some of these events that we care so much about, like heart attack, heart failure, stroke, and progressive kidney disease to needing dialysis. We really want to avoid those. And so prevention is where we're focusing now.